Good day everyone, I hope everything is fine. In this presentation, we will review the anatomy of the colon and the rectum. The embryonic gastrointestinal tract begins developing during the fourth week of gestation. The primitive gut is derived from the endoderm and divided into three segments, namely the foregut, midgut, and the hindgut. Both midgut and hindgut contribute to the colon, rectum, and anus. During the sixth week of gestation, the midgut herniates out of the abdominal cavity and then rotates 270 degrees counterclockwise around the superior mesenteric artery to return to its final position inside the abdominal cavity during the 10th week of gestation. During this age of gestation, the distal most end of the hindgut or the cloaca is divided by the urorectal septum into the urogenital sinus and the rectum. Based on this embryological origin of the GI tract, each segment has its own blood supply and innervation, retaining these relationships throughout the development and into adulthood, and distinctively identify its boundaries as for foregut, it extends from the oropharynx to the duodenum at the level of the entrance of the common bile duct and include the pancreas, liver, biliary tree, and spleen. For the midgut, it composed of distal duodenum, jejunum, ileum, appendix, ascending colon, and proximal two-thirds of the transverse colon. For the hindgut, it consists of the remainder of the colon and the rectum down to the cloacal bulge, which constitute the interface between the surface ectoderm and endoderm of the cloaca, corresponding to the dentate line. A quick review of the anatomy of the colon and rectum. The colon begins at the junction of the terminal ileum and cecum and extends approximately 150 cm to the rectum. The cecum has the widest diameter of the colon and has the thinnest muscular wall. As a result, the cecum is the most vulnerable to perforation and the least vulnerable to obstruction. The ascending colon is usually fixed to the retroperitoneum. The hepatic flexure marks the transition to the transverse colon. The transverse colon is relatively mobile but is tethered by the gastrocolic ligament and colonic mesentery. The splenic flexure marks the transition from the transverse colon to the descending colon. The descending colon is relatively fixed to the retroperitoneum. The sigmoid colon is the narrowest part of the large intestine and extremely mobile. The narrow caliber of the sigmoid colon makes this segment of the large intestine the most vulnerable to obstruction. In general, blood supply of the right colon is derived from the superior mesenteric artery at the rect branch of the abdominal aorta. It branches into ileocolic artery, right colic artery, and middle colic artery. Ileocolic artery, which is also absent in up to 20% of all people, which supplies blood flow to the terminal ileum and proximal ascending colon. The right colic artery supplies the ascending colon, and the middle colic artery supplies the transverse colon. The inferior mesenteric artery supplies the left side of the colon and branches into left colic artery, which supplies the descending colon, several sigmoidal branches, which supplies the sigmoid colon, and the superior rectal artery, which supplies the proximal rectum. The terminal branches of each artery forms anastomosis with the terminal branches of the adjacent artery and communicate via the marginal artery of Drummond. This arcade is complete in only 15 to 20% of people. The lymphatic drainage of the colon originates in a network of lymphatics in the muscularis mucosa. Lymphatic vessels and lymph nodes follow the regional arteries. Lymph nodes are found on the wall of the bowel is called an epicolic lymph node. Along the inner margin of the bowel adjacent to the arterial arcades is called paracolic lymph nodes. Around the named mesenteric vessels is called intermediate nodes, and the origin of the superior and inferior mesenteric artery is known as the main or the principal lymph nodes. The colon is the major site for water absorption and electrolyte exchange. Under normal circumstances, approximately 90% of water contained in ileal fluid is absorbed in the colon, or approximately 1,000 to 2,000 ml per day. But up to 5,000 ml of fluid can be absorbed daily. Short-chain fatty acids, namely the acetate, butyrate, and propionate, are produced by the bacterial fermentation of dietary carbohydrates. Short-chain fatty acids are an important source of energy for the colonic mucosa, and metabolism by colonocytes provides energy for processes such as active transport of sodium. Endogenous microflora in the colon are crucial for the breakdown of carbohydrates and proteins in the colon and participate in the metabolism of bilirubin, bile acids, estrogen, and cholesterol. Colonic bacteria are also necessary for the production of vitamin K. These endogenous bacteria are also thought to suppress the emergence of pathogenic microorganisms, specifically the Clostridium difficile, a phenomenon termed as colonization resistance. As to the motility of the colon, it displays intermittent contraction of either low or high amplitude. Low amplitude, short duration contraction occurs in a burst and appears to move the colonic contents both antegrade and retrograde. While defecation is a complex coordinated mechanism involving colonic mass movement, which increases intra-abdominal and rectal pressure and relaxation of the pelvic floor, defecation proceeds by a coordinating increasing intra-abdominal pressure via a Valsalva maneuver with the rectal contraction, relaxation of the puborectalis muscle, and opening of the anal canal. Moreover, continence requires adequate rectal wall compliance to accommodate the fecal bolus, appropriate neurogenic control of the pelvic floor, and sphincter mechanism, and functional internal and external sphincter muscles. In the clinical evaluation of patients with GI problem, obtaining a complete history and performing a physical examination are the starting points for evaluating any patients with suspected disease of colon, rectum, or anus. Special attention should be paid to the patient's past medical history with the current medication that the patient is taking and surgical history to detect underlying conditions that might contribute to the GI problem. A history of anorectal surgery may be critical to patients with either abdominal or anorectal complaints. Other information related to the medical problem and information related to obstetrical history in females or family history, especially related to anorectal problems, that may suggest the presence of genetic syndrome. Doing digital rectal examination is very important to note for the sphincteric function of the patient as well as the pelvic floor function or the presence of anorectal masses and to assess the location of the mass, the morphology, the number of quadrants that is involved, the degree of fixation against the bowel wall, its mobility, and extrarectal growth involved in the tumor, or is there any direct continuity with other structures such as, for example, in the vagina, which is involved by the tumor. This ends my presentation on the anatomy of the colon and rectum. Thank you, everyone.